Good morning. I'm delighted to be here. And I want to begin with a story about a community health worker here in Nashville. She was walking across Centennial Park on a beautiful sunny day like today when she saw something glistening in the grass. She reached down to pick it up and rubbed gently. And out of that lamp, a genie miraculously appeared. And the genie said, "For your kindness, I will grant you one wish." She thought for a moment and said, "Paris. I've always wanted to go to Paris. Build me a bridge from Nashville to Paris." The genie thought, "I'm sorry, I just don't think that's possible. Imagine the amount of concrete that would be needed, the length of the steel girders, the depth of the pylons to the bottom of the Atlantic Ocean. And imagine the number of workers that would be required to build a bridge such as this. I'm sorry, it's just not possible." So the community health worker thought for a moment and said, "Well then, help me to understand the people who I serve. Help me to understand their behavior and biology, the role of stress and social conditions. Help me to improve health here in my community." And to that, the genie said, "Did you want 2 lanes or 4? Clearly, the implication here is that it is more difficult to understand and improve health in our communities than it is to build a bridge from Nashville to Paris. Some days I agree. This week is the 10th anniversary of the Millennium Development Goals. We've made progress, but there's a long way to go by 2015. Now, I am not going to compare the health challenges of the billions of people who live on less than $1 a day to those we face here in the United States. But I am going to say, whether we live in Nairobi or New Delhi, New Orleans or New York, poverty and health are challenges that we face are preventing us from reaching our full potential. I'm going to focus a bit on the U.S. today with a series of strategies at the end that hopefully can be brought back to our communities, to our nation, and to the world. But let's begin at the beginning. Despite tremendous biomedical and technical advances in the United States, our rates of preterm delivery have increased 36% over the past 3 decades. 500,000 babies every year, 1 in 8, are born premature at a cost to us of $26 billion. On the other end of life, we are losing ground. In 1980, we ranked 14th in the world on life expectancy. In 2010, we ranked 38th. 38th! We rank lower than Cyprus, Chile, and Cuba. And despite the fact that we spend more than twice as much as our neighbors in Japan, we live, on average, 4 years less. So what's happening between preterm delivery and premature mortality? Chronic disease. How many of you here yourselves or have a chronic disease or have a loved one with a chronic disease? Heart disease, lung disease, diabetes, or many cancers? Nearly everyone in this room. Therefore, it's not surprising to learn that 75% of our $2.5 trillion in healthcare expenditures are attributable to chronic disease. We are smoking, and we are getting fatter year by year. So much so that 1/3 of our children and 2/3 of all adults in the United States are overweight or obese. If we did what we know works, if we quit smoking, had a healthy diet, and exercised, we could reduce 50% of all morbidity and mortality, 50% of all illness and death attributable to chronic disease. But it's not so easy. These are considered proximal causes to chronic disease, but there are deeper social determinants as well, the cause of the causes. Social and community networks influence our health, as do socioeconomic, cultural, and environmental conditions. In fact, it's estimated that only about 10% of differences in health can be attributed to access to health care. Another 30% to genetics or hereditary factors. The majority to behavior, to social conditions, and to our environment. And so it's things like agricultural and food production, work and living conditions, housing and transportation that influences our health. Place matters. This is a map of Washington, D.C. If you were a resident of Washington, D.C., your average life expectancy would be 72 years. For those of you who have been to Washington, D.C., you may recognize this as a schema of their metro system. If you traveled 30 miles to your home in Montgomery County, Maryland, your average life expectancy would be 9 years longer than your brothers and sisters in Washington. And this isn't just true in Washington, D.C. On the eastern seaboard, you see again Montgomery County, Maryland, with a life expectancy of 81.3 years, the same as in Sioux County, Iowa. Travel just about 500 miles west to Bennett County, South Dakota, and you've lost 15 years of life expectancy. Poverty and social determinants of health are influencing our lives from birth to death and in between. Income is linked with health regardless of racial or ethnic group. The dark green bars represent those in the highest levels of poverty, and as the color gets lighter, our income increases. And you see here what we call a socioeconomic gradient. Those in the highest poverty are most likely to rate their health as fair or poor. And then we see this gradient down with the more money, more income, we are less likely to rate our health as fair or poor, whether we are Black, Hispanic, or white. And so we have a tremendous wealth disparity in this nation, and with it comes a tremendous health disparity. We heard today that poverty is highest it's ever been, 43.6 million people, 14% of our nation. 49 million Americans and rising have food insecurity, not enough food or money for food. 17 million children. And so the faces of hunger are these, young and old, Black, white, and brown. Let's turn for a moment to education. High school dropouts in the U.S., 1.3 million a year. Every 10 seconds, a child drops out of school. Since I've been speaking, we've lost about 50 kids, including 1/2 of Black and Latino youth. at a cost to the nation of $330 billion in potential earnings. But that just scratches the surface when we think of the losses of human potential. Some of you may be thinking, why is she talking about education? But education and health are inextricably tied. Healthy children are better able to learn. And those who are well educated, like those with more money, are healthier. Those with less than a high school education, 1 in 4, rate their health as fair or poor, compared to only about 6% of those with college degrees. Melinda Gates said Monday, change is possible. I'd like to close with 3 strategies for achieving that change. We need to mobilize. We need to marshal resources for action. We can and we must do better. We need to bring evidence to action. We need to take what we know works, programs and policies that can improve health, and bring them to our communities in Nashville, in New York, and all around the world. This is not a new idea. Abu Bakr in the 6th century said, without knowledge, action is useless, and knowledge without action is futile. So here are those 3 strategies. First, we must mobilize resources. Yeah, it's going to take knocking on doors and sitting on stoops. We need to understand people's lives, their families, their social conditions at home and in their schools and workplaces. When we talk about mobilizing resources, it takes money too. We need to think about public and private partnerships, working with the business community and the philanthropic community, with the faith community and schools and health centers and work sites. Second, we need to mobilize research. Did you know that it takes 17 years to get from scientific discovery to change in health in our communities? 17 years is too long. Last fall, we mobilized local resources for research. We hired 32 women and men from the New Haven community where I work, and we knocked on doors and we sat on stoops. And in 7 weeks, we got a snapshot of health from 2,400 children and adults who we surveyed. So we need to think about efficiency in mobilizing research. We heard today from Nicholas Christakis about social networks and how smoking and obesity is transferred through those networks. Let's mobilize those networks for good. Let's mobilize those networks to improve health in our communities. Number 3, let's mobilize leadership. We need to think about local leaders like the men and women who we hired who know their neighborhoods better than I could ever. And we need to mobilize our political leaders as well, because what it is going to take to improve health in our communities is better corner stores where access to healthier food is affordable, better farmers markets and community gardens. We need to become a smoke-free nation. We need to recognize that public safety is central to public health. If I tell you you should exercise every day, but you don't feel safe walking through your neighborhood, That's not a good prescription for change. So let's embrace public safety as part of public health. Let's create more bikeable and walkable cities, more green spaces to play and to sit and to dream. And let's change the default options. This is Broad Street in London, the epicenter of a cholera epidemic in 1854. In 3 days, 127 people died. By the end of the epidemic, more than 600. Dr. John Snow mobilized resources. He knocked on doors and sat on stoops. He learned from people what was going on in their homes and in their community. He mobilized research. He systematically interviewed them to find out where they work and go to school, where they get their food and their water. And he mapped all of those responses well before GPS was available. He learned that this pump, that the water in this pump was the source of the cholera epidemic. And so together with Reverend Henry Whitehead and the residents of the Soho community in London, they mobilized leadership. They got the city council to remove the handle from this Broad Street pump. And so I say to you, we don't need a bridge from Nashville to Paris. We need to work hard, and it will be hard. We need to work hard to understand health, and we need to mobilize resources, research, and leadership to improve health in our communities as if our lives depended on it, because they do. Thank you.